Welcome to this deep dive. Today, we're exploring what really happens during bedside patient assessment and how healthcare teams communicate effectively.
Yeah, we've got some great material, particularly from Chapter 30, which really gives an inside look at how crucial patient info is gathered and then shared.
Exactly. Our goal here is to, pull out the key insights, show just how thorough patient care aims to be.
And what's really striking, I think, is how systematic it all is. This chapter lays out these essential steps to really get a handle on what a patient's going through.
Okay, so let's jump right in. Health history.
Mhm.
The chapter says this is like a cornerstone when a patient is admitted, building that initial picture.
It's fundamental.
What are the key pieces they're looking for?
Well, it's pretty detailed. Think of it like gathering the patient's whole story. Their basic info, why they're actually there, that's the chief complaint. Then their medical background, past illnesses, any surgeries, allergies, very important, and all the medications they're currently taking.
And it's not just the purely medical stuff, is it? They also dive into family history, social aspects. I see smoking, alcohol use mentioned.
Right. Occupation, who their support system is, that kind of thing. And then there's a review of systems just checking in on different body areas to catch anything missed.
It sounds incredibly comprehensive, almost like a 360 view.
It really aims to be. And, the why behind it is crucial. This history flags potential risks or predispositions that directly shape the care plan,
Okay.
like knowing about asthma history. That immediately tells the team, okay, be extra careful with respiratory checks. Makes sense.
Yeah, that makes total sense.
Yeah.
Okay, next up is general appearance. Now, this might sound, well, obvious, just looking at the patient, but there's a lot packed in there.
Oh, absolutely. It's that immediate, first impression assessment. Are they alert? Do they know who they are, where they are, roughly what time it is? Basic orientation. What's their skin color? Like pale, flushed, maybe even bluish. Their facial expression relaxed. Or are they clearly in pain? Even how they talk, dress, their hygiene, it all adds up.
And things like nutritional status. Do they look well-nourished or underweight? And how they move independently or needing help? It feeds into that initial understanding.
It really does. It's amazing how much you can pick up from just careful observation. These simple things can, raise red flags or offer reassurance pretty quickly. Guides the next steps.
Right. Then the chapter talks about a quick check of cranial nerves for alert patients specifically. It sounds like a focused neuroscreen.
Exactly that. It's targeted. Looks at 12 key nerves controlling things like vision, that's cranial nerve 2,
Okay.
eye movements and pupil reaction that covers nerves 3, 4, and 6. Often checked with Pereller, pupils equal, round, reactive to light and accommodation.
Pearly. Got it.
Then facial expressions like smiling or frowning, nerve 7, swallowing, the gag reflex, that's 9 and 10, and tongue movement, checking symmetry, nerve 12.
So a series of mini tests for these really essential brain pathways seems efficient for a quick baseline check.
It is, and it shows how assessments get tailored, based on the patient's condition right then and there.
Which kind of leads us perfectly into assessment frequency. The chapter contrasts a full head-to-toe assessment with a more focused assessment. What's the difference there?
So the head-to-toe is the big one. Comprehensive, usually on admission, maybe start of a shift, covers all the bases, gets that complete baseline.
Okay, the whole picture.
Right. Whereas a focused assessment is, more targeted and often more frequent. It zeroes in on a specific issue, someone with breathing problems. You'll do more frequent focused respiratory checks, heart patient, more cardiac checks.
So it's about being efficient, putting attention where it's most needed based on what's actively going on. Makes sense.
Precisely. The patient's current needs and any changes really drive how often and how deeply you assess specific areas.
Okay, finally, the chapter hits on SBR communication, a structured tool for professionals talking to each other. This sounds pretty critical.
Oh, it's incredibly important for clarity and safety. SBR gives you that clear framework. S is situation, what's happening right now.
Right, like the example, patient short of breath, O2 sat is down to 88% on 2 liters. Very direct.
Exactly. Then B is background, the relevant context, like admitted for pneumonia, started antibiotics yesterday, just the key facts needed.
A is assessment, your take on what's going on.
Yeah, your professional judgment. So maybe possible worsening infection, or maybe they're just not getting enough oxygen.
And R is recommendation. What do you need or suggest? Like requesting respiratory therapy consult and a chest x-ray.
Perfect. It's just so direct and efficient, cuts down on confusion.
So what SBR really does is standardize that handover, right?
Yeah.
Reduces errors.
Absolutely. It ensures all the critical pieces are there, conveyed concisely, especially vital when things are moving fast or a situation is serious.
So wrapping this up, what we've seen from this chapter is this really methodical approach from getting the full story initially,
The health hits it.
those ongoing focus checks, and then making sure everyone's on the same page using tools like SBAR.
Yeah. And for anyone listening, it just highlights the real rigor involved in good patient care and how crucial, clear, structured communication really is for safety and getting the best outcomes.
It definitely makes you appreciate the process.
Yeah.
And maybe think, how could applying a structured way of gathering info and communicating needs be useful in other complex parts of our lives? Something to ponder. Thanks for digging into this with me.
My pleasure. It's fascinating stuff.